All right, it's time for our Kegel exercises, Twila.
Yes, it is.
And so why do we do our Kegels? Well, it's important for our pelvic health for both men and women. These exercises help support our pelvic organs in women, the bladder, the vagina, the rectum, the urethra. And for some people, it can actually improve sexual functioning. Some people say it makes orgasms more intense and more frequent.
Well, I think that's a good enough reason to do them right
Nobody's going to
there.
argue with that, I don't think. So let's go ahead and do it.
Okay. 3
times a day.
6
Days a week.
9
Seconds per Kegel.
and 12.
Kegels in a row to make a rep. It's so easy. Just do 12 of these 3 times a day. When you're doing them, hold it for 9 seconds. You will be the envy of your neighborhood. You will have a pelvic floor like a chain link fence, so you will be able to pull a trailer.
If you so choose. And don't forget, you can always go to the GynoCast Facebook page and get an infographic, which kind of details out the customizable plan. You can print it out, put it on your fridge. You can put it up in your office. We can share it with your friends. And it's a great resource to have. So Make sure that you go and do your exercises today.
Yes.
Stay tuned.
Hello, everyone, and you are listening to the GynoCast. My name is Dr. Eric Heegaard. I am a board-certified obstetrician-gynecologist, and I'm sitting here with Twila Dang.
Thank you.
I'm not even going to let you introduce yourself.
I don't mind you introducing me once in a while.
I've had some coffee. I'm just going.
Go for it.
Going
How much coffee did you have? Should I be concerned?
I had 12 cups today.
I think I'm a little concerned. Okay, that means I'm going to keep you focused.
That's right.
Today.
Just keep me going.
It's all right.
So you're listening to the GynoCast. If you're new to the GynoCast, welcome aboard. Thank you so much for listening. If you are a recurring addicted member of the GynoCast.
Why did they have to be addicted members of the GynoCast?
Because that's what we are trying to do. We're trying to addictify people.
Just dedicated. Can't they be dedicated listeners?
I don't think that's a word, addictify.
I mean, you're the doctor.
We are trying to create a product that's so fabulous that you cannot, resist getting your information here. So let's talk. So for people who do not know what this show is about, let's tell them what it is. You're good at that.
Oh well, you're
good at a lot of
things. You mean what we do here?
What we do.
Okay. We talk about anything and everything women's emotional and physical health and well-being.
That's right. And we do it well. We talk about the things that people need to talk about, want to talk about, but sometimes don't know where to go.
Absolutely.
We talk about the things that sometimes are not, topics for polite conversation, for milling about with your boss or whatever, with your dry martini with 3 blue cheese olives and,
You're being very descriptive today.
Well, I got to tell you, for those people who don't know, I love a good martini. I think it's transcendent.
Apparently.
And you can go from just being kind of a knucklehead. You have a martini with 3 olives, and all of a sudden you're waxing philosophic.
It's very urban of you. I'll stick to whiskey. Thank you.
And you know what they say about martini? No, I'm not going to actually.
I'm
not going to say. Have I told you? I'm not. Okay,
you were
this
not
is not
going
the
to
place.
tell me.
So again, and now the other thing is,
yes.
If you want more information on the GynoCast, if you feel, sometimes you might feel lonely, you might feel kind of down in the dumps, you might feel, like you just want to feel part of a bigger thing.
Yeah.
Well, there is the GynoCast Facebook group.
That's right.
It's a world of wonder.
It is a world of wonder.
And it is life-changing. So if you're not a member of the GynoCast Facebook group, please join.
Yes.
It's so easy. You just go to Facebook, search GynoCast.
Just go to the search bar, put in the GynoCast.
The GynoCast.
Mm-hmm. And then just you have to join the group. It is a private group. But that's okay. We do that because we do talk about sensitive issues here, and the conversations that we have on the page tend to be sometimes personal, sometimes asking for help or assistance or support. We have fun and lively and respectful conversations there as well, but we want to make sure that the members of the group are people who want to be having those conversations and not just yahoos who see the name GynoCast and think they can cause shenanigans. Yeah. So just go and ask to be a member. We will let you in. It's very quick that we vet you.
That's right.
And I have to say this, just as a sidebar, I've been getting some lovely messages from listeners from the GynoCast page.
Oh, really?
Yeah, just supporting what we're doing and supporting the process of putting together this podcast and getting it up and launched. We've got some really great support, some really great members on there. So if I haven't said it before, thanks. I appreciate it.
To the listeners, or are you thanking me?
Oh, the listeners.
Okay.
Thank you. It's understood.
Okay. So with no further ado, let's get into our topic. I wanted to talk today about an issue that is really of some concern to those of us who are in women's health and obstetrics in particular, and that is cesarean sections. We have a very high C-section rate in the United States.
Okay.
And actually, it's not just, it's something that is happening all around the world. In fact, if you want to know something of interest, I think it is Argentina. It's like a 95% C-section rate, and that's a story for another day.
Okay. I mean, I was going to say, because I figured I know why, right?
Well, hold on that, and we'll ask our guest if he has any insight on this. Our guest today is Dr. Matt Bigus. He is from I was going to say alma mater, but it's not really. I'm just from OBGYN West.
Oh, hey.
The most fabulous obstetrics and gynecology group in the world.
I was going to call him a long-time listener, first-time caller, because this is the first time we've had him as a guest.
No, when we remember in the old days, Twila, when we used to do live radio.
Yes, he's been in the studio with us, and we kind of drafted him.
Oh, that's right.
But this
is the
you
first
weren't really
the guest. Oh,
yeah,
that's right.
we drafted him in because we always drafted people in when they came in the room. But this is the first time he's actually legit, name above the fold and credits.
That's right.
So welcome.
Well, Dr. Bigus, thank you so much for joining us.
Oh, good afternoon. Thank you very much for having me here. I really appreciate it.
Well, and Dr. Bigus is a super smart guy. He's a good egg, which is important because we don't let anybody on the GynoCast who is not a person of good caliber.
There you go.
And so there you go.
High praise.
Don't screw up. All right, we're going to talk about, so I want to talk about cesarean section because we're doing a lot of them. And I think most people agree that perhaps we're doing too many and that we need to sort of try to control this somewhat. And so I want to talk about this sort of status, the state of the state in terms of C-sections. And I also want to talk about what we used to call VBACs. I think people may recognize that term, which is
I do.
Vaginal birth after cesarean section, VBAC. But now it's called TOLAC. Am I saying that right? TOLAC?
We usually refer to it as TOLAC.
TOLAC.
That's the most common way that we say it. So,
what does that mean?
It stands for trial of labor after cesarean section. It's a relatively common procedure that we do. Usually we refer to the labor process as a trial of labor for TOLAC. And once it's successful, we then refer to it as a VBAC or vaginal birth after cesarean. So when we're compiling statistics for hospital-based surveys and nationwide surveys, the actual trial of labor itself prior to the delivery is the TOLAC. When it's successful, we refer to it as the VBAC. So we still use the term VBAC, or the vaginal birth after cesarean section.
All right.
Oh, so it's like two different things. I thought one was
so now we have to remember two things,
right.
Doctor, instead of just one.
I know it gets very confusing for some people who are not sort of in the thick of things doing this all the time, but it really helps us give some statistics as far as success numbers when you look at how many people have attempted a trial of labor and then can compare it to the amount of people who succeeded and had a VBAC.
Right. So why don't you tell us what is kind of the current state of C-sections in the United States? Where are we at in terms of statistics?
Oh, absolutely. So going back in history just a little bit, back in the 1970s and before, there was a common paradigm that a lot of people may have heard of, their mothers or grandmothers talking about, a quote that once a cesarean, always a cesarean. Yeah. With the advent of some of the new electronic fetal monitoring, when we watch the baby's heart rate throughout the whole process, more and more people have tried and attempted this trial of labor after cesarean. Back in the 1980s, when it first started in 1985, it was about 5% of people with a prior cesarean section would attempt and have a successful vaginal birth. This number increased in the 90s up to about 28%. And in the 90s is when they found a lot of data about vaginal births and some of the complications that we worry about with vaginal births. Now, that number since the 90s has actually declined while the cesarean section has risen. The rates of cesarean section are now upwards to 30%. It ranges across the nation from mid-20s up until 40%, depending on what hospital and what type of practice that you're looking at. Now, since we're based in Minnesota, Minnesota itself has a cesarean section rate of 27.3%.
Not bad.
Yeah. Now, I did my residency, which I'm fresh from finishing as a senior resident in Pennsylvania, where we had about a 31.4% rate of cesarean. Where I trained at Hershey Medical Center, we had about a 35% cesarean section rate, which oftentimes when you're looking at academic centers, they have a tendency to have higher numbers, both because of the training programs and because of the high-risk population that they deal with, because they have a dedicated maternal-fetal medicine subspecialties that run through their labor and delivery units with very sick babies and very sick mothers who it's probably safest for delivery would be a cesarean section for
right. So you can't compare necessarily. It's not apples to apples.
Right.
There's different populations.
Exactly. And when you're looking at statistics across the nation, oftentimes they take all comers, and when you're doing that, you're including in those academic centers, which can have upwards of 40%. But that's not to say that academic centers are bad for delivery. They just have a sicker, more acute population that doesn't really go along with the average woman who's pregnant in labor.
Twila, you look like you want to say something.
I guess I have a couple questions.
Yeah.
One, is are those numbers, like you gave us the Minnesota numbers because that's where we're located. You gave us your numbers from your residency, like in Pennsylvania. Are those like higher numbers in the country, or where are the highest numbers sort of situated?
So they basically say the numbers range between the two, but pretty much the average is about a third. So somewhere around 30% to low 30s would probably be the most average. People try to strive to get down to around 25% as sort of a goal number for the time being. And the American College of Obstetrics and Gynecologists have actually talked to us and put out some bulletins to help us to try to lower these numbers for cesarean section. They actually came out with a consensus statement called the Safe Prevention of Primary Cesarean Delivery, which was published in March of 2014, where they really are trying to give us some effort and some ways to decrease those numbers to get them back to a more a safer number.
Does anybody know why that sort of 90s hit where it kind of skyrocketed up? Were there any what were the factors that kind of caused those numbers to jump like that?
I mean, the numbers in terms of people trying to have a vaginal delivery after C-section, or the number of C-sections themselves?
Yeah, like the number, sort of that. I believe you had talked a little bit earlier about sort of how there was somewhere in the 90s there was an increase in that number.
Yes, and then that number has fallen.
Yeah, was there any particular reason why in that particular time frame we saw that shoot up?
That is a darn good question.
I like to ask good questions.
Yeah, and it's a complicated question because there's a lot of things going on. And, let me just jump back for a second, because just to give people some perspective, which is I think that, if you start talking about 30, 40, 50 years ago, the C-section rate was, I think, 10 or 15%.
Oh, wow.
So that was back in the old days, and, now it's progressed up to over 30%. Mm-hmm. And so, yeah, you asked the question why, and Dr. Bigus, I'm going to let you answer that, because you are a complex thinker.
So in the 90s, with some more of the data coming out, that the safety of a vaginal delivery was oftentimes thought to be a little paramount over a repeat cesarean section. Because if you compare a vaginal delivery to a cesarean section, just standalone between the two, vaginal delivery for mom is technically a safer route of delivery. It's less complications, less blood loss, less time for recovery, less pain with recovery, less scarring involved, and all in all, it's in the mother's best interest for a vaginal delivery.
Right.
As far as the baby goes, it's really a wash whether it's vaginal or cesarean section, as long as they're tolerating a labor process. The risks really aren't different between the two. But when you start looking at that factor alone, in the 90s is what they did, and they started really pushing everyone towards vaginal delivery. And then the insurance companies oftentimes got involved, and they started incentivizing vaginal delivery over cesarean, which is why the numbers really started getting pushed to have a trial labor. In fact, they started doing a lot of trial labors, which now we would probably consider unsafe.
Well, and actually, I think that, when we start talking about pendulums going back and forth, and there was a time when, again, just like now, we felt like there were too many C-sections, and then the push came for a lot of reasons to try to do trial of labor, and then we started seeing complications. I remember back, and this was probably, 15, 20 years ago, that there was, here in the Twin Cities, there were a couple, I think, more than one situations where, I'm just going to say, it was definitely more than one, where, uterine ruptures and some catastrophic results. And so, it's something where, you want to find that balance between trying to do what's best for everyone.
Absolutely. And that's sort of where things changed in the 90s, because the more and more they did these, that's when they started finding out the complications associated with the trial of labors. Because it is, I guess, technically what you would consider a procedure, there are some additional risks with having a trial labor that you would not have with a regular vaginal delivery. And a lot of this is found out from the data in the 90s. Unfortunately, there's no chance anyone to perform what we consider the gold standard trial, a randomized control trial on this. All the data was observational and retrospective, meaning looking back in time.
Right.
And they found out that uterine rupture was probably the number one concern for a trial of labor. And
well, tell people, I know it probably sounds obvious, but what does that mean?
Sure,
exactly?
Absolutely. So the uterine rupture is when you have a uterus, which is basically a organ that's structured like a sac that's made of muscle. There's a scar in the muscle from the previous surgery. That scar, as you probably know from, if you ever had scars yourself, that scar is weaker than the rest of that muscle itself.
Right.
So there is a very small chance that with repeated contractions over and over and over again, that scar weakens, pulls apart, and eventually ruptures or tears apart, tearing a hole in the uterus itself.
Right.
That is considered a uterine rupture. Now, that rupture can be catastrophic for both mom and baby, because as it ruptures, if it ruptures up through the more muscular or top portion of the uterus, that can turn into real bad news real quickly for both mom and baby, with fetal losses being described, as well as torrential hemorrhages. And these ruptures are what we try at all costs to avoid. And if you look at people who've had what we consider a safe for trial of labor cesarean section, or a scar on their uterus that is a low and transverse, then those patients have a less than 1% risk of rupture. The number itself is actually 0.5 to 0.9% quoted in the literature for risk of rupture. That is a low enough number that if you weigh the benefits of vaginal delivery over cesarean section versus that risk of rupture, that is a safe number to use to attempt a trial of labor. Now, if you have a incision on your uterus that is up and down and goes through the muscular part of the top portion of the uterus, that is much weaker and is more likely to rupture, with somewhere around let's say a 10% chance.
So for people who don't understand this, if you can imagine, as Dr. Bigus said, that the uterus is like a muscular bag, and it's kind of shaped like an avocado. In this case, it would be a huge avocado in your term, but the thickness of the uterine wall down by the lower part, the thinnest part or the narrowest part of the avocado, the part that is near the cervix going into the vagina, is the thinnest part, whereas at the top of the uterus it gets to be very thick, and it's that thick portion that is exerting the pressure of labor, correct? And that's what's contracting and pushing the baby down. Mm-hmm. And so what Dr. Bigus is saying is that if there's different ways of making incisions in the uterus, we almost always make an incision in that low, thin part where there's less pressure exerted. But under very rare circumstances, sometimes people need to have an incision in that thick muscular mm-hmm. area, and that is where the most pressure is being exerted, so it's a higher risk of it.
Absolutely.
Of separating.
Support for the GynoCast is provided by OBGYN West. OBGYN West provides the highest quality care from compassionate providers, including women's health issues from general sexual health to pregnancy care, childbirth, menopause, and beyond. Whether it's your teen's first annual exam, a new baby's on the way, or you're facing the special challenges of middle age, OBGYN West provides a wide array of services. Their doctors and PAs are trained in virtually every type of OBGYN service and procedure. OBGYN West provides exceptional care for women.
Okay, well, riddle me this. Can you talk a little bit about what the philosophy is for somebody that would be considering a VBAC, say a pregnant woman? You know, we'll probably have some listeners that are first-time listeners, or they had a C-section before, or they're trying to figure out their options. What's sort of the methodology that you think a woman approaches when she's considering a VBAC after she's already had a cesarean?
So are you asking, like, why would somebody decide?
Why would somebody try to decide to do that?
Yeah, Dr. Bigus.
So I know we just spent a lot of time talking about a little doom and gloom about the risks of something and those catastrophic reasons, but that's why we're here. That's what we always try to monitor and prevent and manage if something like that were to happen. The vast majority of people who do go through a trial of labor, say 99%, because that risk that we just talked about is so low, less than 1%, those patients have perfectly fine vaginal deliveries with no complications, just like they would a regular vaginal delivery. The only other thing to worry about is whether or not your trial of labor will be successful. There's always a chance of failure for these trial of labors, especially depending on why your first cesarean section was. Mm-hmm. That kind of brings us to some of the things that they found out in the 90s as far as factors that make you more likely to have a successful vaginal birth.
Let me just clarify something, because that's a great point, because I think that Dr. Bigus and I are trying to normalize this a little bit, and which is that, you know, he said that the major thing that we worry about, of course, is the uterine rupture.
Mm-hmm. Right.
Less than 1% chance of that is what Dr. Bigus is saying. But even, you know, and most women who want to do a trial of labor are successful at it. But even if it's not successful, doesn't mean that there's going to be some sort of catastrophic event. It's not like you're either successful or there's a catastrophe. Mm-hmm. Mm-hmm. You know, if it doesn't work, you end up having a C-section again.
Right, exactly. And we always mention that first part about the uterine rupture because that is the most important part for us to monitor a patient for, to make sure that things are safe for both her and the baby. As long as things are safe, then it's totally fine to continue with a trial of labor. Now, when we start talking about the more likely is the success factor, there's a lot of different ways and prediction models that have been coming out to help try to give you a number to wrap your head around as far as what your personal, individualized success rate would be. One of the things that has been found to be very useful is actually on the internet, pretty much free for access for everyone, is a website where we can sort of plug in your own personal data and we can talk about your own success rate for a trial of labor. Now, the things that we found to be strong predictors for probability of success are whether or not you've had a prior vaginal birth before and whether or not you go into spontaneous labor. Ideally, the candidate would be someone who's had multiple vaginal deliveries before, who then had a cesarean section for, something like breech presentation.
When the baby's upside down.
Mm-hmm. And then she comes into labor on her own. She presents in active labor, contracting, having broken her water, progressing on her own without our intervention. Those are the strongest predictors. Now, other things that will decrease your probability of success are going to be if your indication for cesarean section was something that we refer to as a labor dystocia. Now, that's a fancy way to say that your labor process did not work properly. So oftentimes you'll hear us say arrest of descent, arrest of dilation, or just arrest of labor, meaning that the baby got stuck in the birth canal on the way down, and you had to have a cesarean section to deliver that. If your baby was previously delivered for that indication, that would portend poor outcomes for a trial of labor. Other things include women of advanced maternal age. We use the number 35 as our cutoff for advanced maternal age.
So at 34.9, everything's good, but 35.1,
35 and up is
just everything just disintegrates.
Well, sometimes you have to draw a line in the sand.
Good to know.
But you know, people, you know, it's just I'm obviously speaking tongue in cheek here, but it's just sort of funny how people do ask these questions of us. Well, what happens when I get 35?
Yeah.
I think people we have done a bad job of kind of communicating this. I think people think that at 35, like everything just sort of literally just unravels.
It does. I'm a woman. You should know.
Twila.
No, I'm kidding. But we have done some shows about infertility. So we've talked about how a lot of women today are sort of delaying their childbearing years.
Yeah.
So that definitely comes into play if you've decided that you don't even want to start a process to have a child until you're 35 or over 35. And then you have to sort of think about what happens on the back end once if you're able to get pregnant. There are going to be decisions you have to make. Yeah.
So, Dr. Bigus, you're saying the best prognostic. So, we're putting ourselves in the situation of a woman who's had a C-section before. Mm-hmm. She's trying to make this decision. Mm-hmm. So, the best prognostic sign in terms of being able to do this successfully is having had a vaginal delivery before. Mm-hmm. Number one, correct. and having a C-section due to something that was not necessarily repeatable.
Correct.
Something like you said, the baby's upside down, it's breech, or there was just the baby wasn't tolerating labor for some reason. It had to be done in an emergency.
So when you say repeatable, do you mean something that, in terms of it's not life-threatening to the mom, or that it's something that's more of a condition of the baby?
I think more in this
both,
in this situation is pretty much as long as it wasn't an indication that the baby was stuck.
Right. Exactly. Okay, that's a good way to put it. That what Dr. Bigus was saying is that really the worst thing is if a woman goes into natural labor, the baby, she dilates, and either she doesn't dilate completely or the baby doesn't come down all the way. It doesn't work because that makes you think there's something, something anatomically going on, which basically the baby's too big for her particular pelvis.
Correct.
And that would be something that would perhaps happen again.
Right. Oh, okay. I got you.
Am I saying that right? Would you agree with that?
I would agree.
And we should point out, Dr. Bigus referred to a calculator that you can get on the internet. Mm-hmm. We'll put that in the syllabus. So people will be able to get, if you go to our website at matriarchdm.com, you'll be able to see the syllabus for the episode, and we'll have links to everything that we've talked about, including a direct link to that calendar if you'd like to check it out and use it.
So I wanted to go back to something you said, Twila, because I'm not sure whether we answered your question, which is you said, basically I got the sense is why would somebody choose to try to do this?
Yes, and I said my perspective, I didn't have this experience. I had 3 vaginal births, and I had a little bit of difficulty, but it was more of the, for lack of a better phrase, they were able to sort of reach in and turn something around, and then the kid just came out just fine. So I never had to make a decision, but I had a very close friend who had 1 C-section, really wanted to consider went through a process of talking about, a VBAC back when we were having babies, they still called it a VBAC. Mm-hmm. And then I think because her situation was more, she was having issues. I think she was having issues with like a preeclampsia type issues. So it just wasn't even going to be something she could consider.
Preeclampsia being high blood pressure, a condition that results in high blood pressure in labor and other particular situations that put people at high risk. I'm just trying to. I'm doing. I'm subtitling you.
I appreciate that. So I think.
Look at you throwing out the medical talk. It's
listen, I'm old hat with this baby business. I got you on this. Don't ask me about menopause. I'm not there yet. I got the baby stuff down. But I guess just sort of from your perspective as doctors who have seen patients, what kind of what was the thought process that some of the mothers were asking you or telling you about in terms of a process like this?
Yeah, so I would say that the primary thing that most people want out of a vaginal delivery is the faster recovery, the less blood loss. It's just easier for mom to get through the delivery process, recover from the delivery itself in order to spend time with her baby. And that, with a vaginal birth after cesarean section, is much quicker and easier for her to do and kind of bounce back into, at this point she's at least got 2 babies because she's had 1 prior C-section for her first baby. Now it's her second, having to deal with 2 little ones running around the house. It's easier for her to bounce back from that delivery, to do her mom thing and be that that mom for her kids that she wants to be. It's easier, it's faster, it's safer for her to have a successful VBAC than it is to have necessarily a repeat cesarean section. Now, it doesn't mean that cesarean sections are, oh my God, they're terrible, because a uncomplicated scheduled cesarean section, you can have the same thing. It's just a little bit slower recovery for mom, and overall, most mothers who have those do just fine as well. Right. But the other thing is for women who want to have large families, you don't want to have repeat after repeat after repeat cesarean section. Yeah. Because once you start getting into multiple repeat cesarean sections, you start worrying about some other complications that are going on with the scar tissue that's formed after every surgery. Now, surgery itself always begets scar tissue, and scar tissue kind of distorts anatomy. Scar tissue makes surgeries harder, longer for us to do, harder to recover from. And when you start having multiple surgeries, your risks of the surgery itself get higher. Your blood loss gets higher. Your chance of injury to other structures that are in places where they don't belong. For example, you could have bowel that's adherent to the wall of the uterus that you don't know about as a surgeon from prior scar tissue. And that is part of the reason why it takes us longer and there's more chance of injury when you have multiple cesarean sections. So when a woman wants to have a large family, the best option is to try to have as many vaginal deliveries as possible and minimize that.
That was one thing I actually wanted to address with you, because that's something, a conversation I have with people. Like, going back to what you asked, Twila, like, I don't know what your experience has been, Dr. Bigus, but some people they've had one C-section for whatever reason. Mm-hmm. They come in and you're talking to them, and some people, they literally come in and said, "I just want to do another C-section. It went great. I had a great experience. I don't even want to go through this process." That's one conversation. Mm-hmm. And so, but one of the other things it might be that even despite what Dr. Bigus was saying, in addition to what Dr. Bigus was saying, which is, just the recovery is faster with having a vaginal delivery if it goes well, etc. For many people, for some people, they just want that experience. It's just from a philosophical standpoint, from a, reasons that, are just very personal. They want to have that experience of having a vaginal delivery.
No, that makes sense. I mean, I didn't want to have it. I just wound up. That's just how it worked out.
But yeah.
I understand fully. There are some people that I know that were just that's the heart call to them. It's super personal to them. And I was the fool that was just like, I'm not going to birthing classes. I'm just gonna take all the drugs. Yeah. I don't need to know how to breathe. I'm just going to take all the drugs. And then everything happened so fast. They're like, honey, it's too late for drugs for you. And then I was like, I had to get a whole education about how to push a baby out in about 5 minutes. Yeah. But I know some people that, it's highly personal. It's, they've dreamed of having families their whole lives. They've dreamed of having that experience. And having had that experience, I understand fully why someone would want to have that experience to some extent, because for as much as you black out, there is still this sort of amazing thing that your body does that other people, half the population of the world, can't do. So when you get a chance to do it, it feels like it's an honor to have had a chance to do it. So I get that too.
Yeah, it's just one of those very personal things that for some people, like you, Twila, you didn't care, just as long as the baby came out safe and sound. Mm-hmm. It didn't really matter. But for some people, it's really it's a big deal, and to not be able to do it is they kind of grieve it.
Yeah, and I understand that. That's, very much like the process of, if you go through something like this and find out that you cannot bear your own children, that's a difficult process. When you've decided, when you've made a decision, when you've had, sort of a life philosophy that this was going to be a part of your life and it isn't, that's an adjustment.
So, Dr. Bigus, let's do a hypothetical thing, which is just take a little bit of time. Let's say a woman comes into your office. Mm-hmm. She's had one C-section. She's thinking about, what to do. She's now pregnant. She's thinking about planning. Mm-hmm. What would you do in terms of, give us the conversation you would sort of have, the questions you would ask?
Absolutely. So the first thing I would want to start with her is, what is her reproductive health plans for the rest of her life?
Like how many babies?
Exactly. And that kind of starts the conversation, because if she says to me, I want to have a large family, 6, 7, 8 kids, I'm going to talk with her extensively about having vaginal deliveries, to avoid all those complications with C-section. Yeah. And we'll sort of tailor the conversation a little bit more with that in mind. Now, versus if she says, oh, this is it, 2 and I'm done, I want absolutely no more children than this, in fact, I'd like to get my tubes tied and be done, then that's sort of a different bent and a different way that we're going to look for the conversation. Now, more than likely, the patient comes in and she says to me, I don't know. It's whatever. We'll have this baby and we'll find out what the future brings. And that's the most common thing that I've probably heard so far in my experience. And for women like that, well, then we start talking about what's going to be the safer option. And we start talking about the vaginal delivery versus the repeat cesarean section. And we mention all the things that we've already talked about as far as the benefits of having the vaginal delivery. And then we touch on, if we go that route, what are the small risks of complications that we have to look at and what we're going to have to do for that. I oftentimes will bring up and give her a success rate for her delivery based off of her own individual size, weights, prior history, and give her a number and allow her and her partner to take some time to think about it. I never make them make that decision that very day. I give them at least, a good solid month to 2 months to really think about it and mull it over. Come back to the next appointment with some other questions, things that we haven't really touched on or more that they want to know, and sort of work with them as a dynamic conversation throughout the whole process as far as what they would like to do.
So, the thing is, the range of success, I think, is sort of surprising. I think most people don't realize that actually the chance of being successful in terms of having a vaginal birth after a previous C-section is actually not bad. Mm-hmm. It can go from not bad to pretty good.
Right.
And so what are some of those ranges?
Sure. So probably the most common numbers are somewhere in the 60s to 80s as far as your percent chance of success. Nothing is ever 100%. Nothing is ever 0%. Really, you kind of take in their own personal history, like we talked about before. Have they had prior deliveries? Have they had issues with the baby getting stuck? How tall are they? What's their weight? All these things, and we come up with that number for them. And that number oftentimes will give you sort of a sense for them as far as numbers that they are willing to do, because you also want to try to avoid a failed trial of labor. A failed trial of labor, meaning that a patient has labored and then is unsuccessful at having a vaginal delivery and has to have a repeat cesarean section, is oftentimes a much more difficult process to do than a elective cesarean section where, everything is scheduled. You come in the morning, and then you have a safe delivery. When you are laboring, oftentimes for a failed process, it could be an emergency situation, or it could be any other reason that it's not working well. And, we'll also start talking about what we need to do in the labor process with the patient to guarantee, or not guarantee, to give her the best outcomes, to have her have the safest labor process possible.
So one of the things, if I'm getting from you, one of the decision sort of trees that you're going down, which is the first thing you want to try to find out what their goals are. And number two, you want
Correct.
to give them an idea of what are the probabilities for success depending on their own individual situation. Mm-hmm. And there are going to be people probably that you would just say, no, this is not a good idea.
Unfortunately, there are those patients. You kind of lay out all the details. You lay out the risks. You talk to them about, for whatever reason, you had a cesarean section at, let's say, 27 weeks for ruptured membranes, and your water broke at 27 weeks, and it was an emergency, and you had what we call classical, or that vertical incision on the uterus through the muscular belly, and they have a high rate of complications. I would tell that patient, unfortunately, I would not offer you a trial of labor. And it really gets individualized per person on that situation.
Or the situation where somebody who just comes in and says, well, I've already had 6 C-sections, but I really want to have it.
Absolutely.
I really want this 7th one to be natural.
Right, exactly. And, you kind of have to take the situation at hand, put it all together, and sort of have that conversation with the patient. As to what your decision-making process is and why you're leaning that way, and why you would unfortunately not offer them a trial of labor.
And on the flip side, there are people, if you've had 6 vaginal deliveries and the last one happened because the baby was breech, you would be going the other direction, which is
absolutely.
You'd be a great saying something to the effect that you're a great candidate for
correct
if this is what you want.
Mm-hmm.
So tell us a little bit about what happens during labor. So they come in, let's just say that you have somebody who wants to do a trial of labor after C-section. What's going to happen in the hospital that may be different than just a normal somebody coming in
absolutely
who has not had a C-section?
Sure. So the biggest number one thing that you need to do is, because of that 1% risk or less than 1% risk of a uterine rupture, which is the scariest outcome that can happen, we do request that all women go through continuous fetal monitoring throughout the entire process.
So we're looking at the baby's heart
absolutely
continuously.
Correct, because the baby's heart rate is going to be the number one first indicator that something is going wrong with the trial of labor. If the uterus is starting to separate and there's concern that things are changing, the very first sign that you're going to see is a change in the heart rate. You're going to start seeing that the baby is not tolerating this labor process, and that's when you would need to intervene. In addition to that, you have to be on hand throughout their whole labor process, because things can change rather quickly in labor. Labor is always a very unpredictable thing, and when it's a trial of labor after cesarean section, that unpredictability can become very dangerous for the woman, and
quickly as well.
Correct, and which is why the physician needs to be in the building on labor and delivery with her throughout the entire process. Now, not necessarily in the room, but available quickly at all times to come in case there is a catastrophic outcome, in order to intervene immediately. And that's sort of where the crux of not all groups across the Twin Cities and across the nation offer trial of labors, because the way that things are set up, not all physicians are able to spend an entire day with a patient on labor and delivery, because they have other obligations to other patients. And unfortunately, some groups will not be able to offer those trial of labors. Now, some groups do set things up to allow that to happen, but you have to find the right group that does provide trial of labors.
Yeah, if that's a priority for you.
Absolutely.
So, Dr. Bigus, thank you so much for joining us. If you want more information on Dr. Bigus, where can they go? Twila?
They can go to our website. So go to matriarchdm.com. You'll be able to get to our page for the GynoCast. In the syllabus, you'll get some information on Dr. Bigus, how to get a hold of him at his practice.
How to pronounce his name properly.
I think we did a good job today, right?
Did it perfectly.
I got to tell you, and for those of you...
You're not doing it.
I'm not saying it,
but
my
ratings.
I'm just saying that it doesn't take... his name is spelled Bigos. But you can imagine how, if you might...
You can imagine if you know Dr. E, how you'd mess that up.
I found it very difficult. I have to concentrate to say it.
Super difficult.
So
yes.
Just make sure you say it right.
Well, that's okay.
Although he doesn't seem to be offended by however you say it.
Well, he knows you. He's a good sport. It's all right. But we'll make sure that you get connected. As always, you'll be able to get the information at the website. You'll also be able to get the information on the GynoCast Facebook page. So if you're already a member, you can just go straight to the page. The link for the show will be up, and you'll be able to follow through and get more information. Don't forget, you can also email us through that page.
That's right.
So if you're at the GynoCast page, hit the send message button, and then you can send us an anonymous message or a private message to ask us a specific question. Pretty soon we're going to do a mailbag show where we go over some of these things and make sure that we get that information back out to the public. But in the meantime, Dr. E always goes through there and answers questions that are posed. He doesn't wait until I kind of organize things on this end. He always makes sure to get back to you right away. So make sure if you have a question, you go ahead and you ask it as well.
Beep, 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 beep,
Why are we
beep,
beeping?
beep. I realized that for those of you who are tired of this, just feel like this has gone on too long, just go ahead and shut it off.
No.
But okay, don't
tell them that.
But there's a couple things I wanted to say, Twila, that I can't believe it. I wanted to throw this out.
Just say it. You can do that here. We don't run out of airtime. Okay.
So for people who need more.
Okay.
Need more.
Mm-hmm.
I want to... Biggest, I know you know this. Mm-hmm. Twila, you probably do know this too. But this is just kind of... Okay. The history of Cesarean section. Who was thought to be the...
Wait a minute. What are you doing?
What do you mean?
What are you doing?
I'm throwing out a little trivia.
I know you would throw out a little trivia after we get.
I know.
To
Well,
the end of
that's what I mean. Is that when are we going to do this again? This is the show on C-sections.
You're adorable. Go ahead.
I'm just throwing this out because I can't believe I forgot
You're
this.
You're as entertaining as my 8-year-old. Go for it.
I was so focused on Bigus.
I know. I appreciate that. But go ahead.
When you see Bigus, you can't not look at him.
You can't. Okay.
So what is the where does the name come from? What is supposed to be the first C-section that was done?
I don't know.
Oh, for God's sake. Cesarean.
Oh, okay. And?
Julius.
Julius Caesar?
Yeah.
Really?
No, it's from the Caesar salad.
I mean, that's where he made that too, right? So I'm going to go with that.
It's all... No, yeah, Julius Caesar apparently was delivered by C-section. Unfortunately, I don't think his mom did so well.
Well.
But he did. And later went on to become...
Julius
Caesar.
Yeah.
Julius Caesar.
Wow.
And so that's the name came from. Now, one more quick thing, but I just think this is just fascinating.
Okay.
They've done C-sections for a long time, for many, 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 many generations and hundreds of years.
Yes.
It did not tend to do well for the mother.
Well.
Not
very much did very well for us back then.
Yeah, and so in general, it was basically to try to save the life of the baby. Correct,
Okay.
Dr.
Correct,
Bigus?
absolutely.
Okay, so here's the final quiz question.
Okay, go
I'll
for
give
it.
this to both of you because I don't think Bigus, even Bigus, probably doesn't know this.
Okay, let's go.
Okay, in 1853, who underwent a successful cesarean section, survived, and paved the way for kind of modern cesarean sections and anesthesia, etc. You want me to repeat that?
Mary Todd Lincoln. I'm just guessing.
I thought you were going to say Mary Tyler Moore.
No, I don't know.
She's not that old. In fact, she's unfortunately deceased.
Yeah, she's gone.
Okay, Bigus, you got it?
I don't have the name here. Is this the one that started with ether? Is this the first time they used ether?
No.
Okay.
What's it? All you?
Chloroform.
Well.
Okay, so this is the answer. Queen Victoria used chloroform as an anesthetic during the birth of Prince.
Listen.
That's right, Leopoldo.
I'm just mad at you because if I had time, I'm so busy making these podcasts, I don't have time to watch the stuff on my DVR where Queen Victoria sits in the DVR having from PBS's Masterpiece Theater, and I would know this if I had time to watch things. So I feel like that was a trick question.
Well,
but that's okay.
But isn't that interesting? That
it is interesting.
How many kids does she have, Bigus? You should know this.
I don't know.
There's she had like 20. She had like 8 kids, and at one point, one of her children was the king of virtually almost every kingdom in Europe, or grandchild. Her family, the king of the Tsar of Russia, the king of England, they were all related.
I can't wait.
And she held the whole thing together. Nobody wanted to fight each other because they were all related.
I can't.
And then she died, and everything went to hell.
Till we get the reviews for this, and it says, "Well, I was listening to the Gynocast, and somewhere it veered into hardcore history, and I don't know what happened." Yeah, I'm gonna love this.
All right, well, more to come. So again, Dr. Bigus, thank you so much for joining us.
Thank you very much for having
thank you
me.
for joining me today, and I'm gonna, you need to give yourself a little pat on the back. Dr. Heegaard, thank you so much for joining me today on my own show.
Indeed. Thanks for listening. We'll be back soon.